Okay, so I think many of you may have read about some innovative therapies, stem cell therapy, CAR T cell therapy, and there's recently been a lot of media interest, particularly around lupus patients, where the intervention of CAR T cell therapy has been incredibly effective. But we are still at the early stages, and so I think we have to be cautious. But here to tell us more about this potential brave new world is the Distinguished Professor of Rheumatology at the University of Zurich, Oliver Distler. Oliver heads up the Centre of Experimental Rheumatology, which was awarded the EULAR Centre of Excellence in 2020 because of its huge scientific achievements. So we are very honoured to have Oliver joining us today.
Well, thank you very much for that. Can you hear me well? For that kind introduction. I just arrived on time. The trains were on time. The plane was on time. UK railway system was on time. So I was on time. So perfect timing. So it's a pleasure to be here, and it's a great honor to be invited. And I was asked to talk about the new cellular-based therapies, which is in particular CAR T cells, and probably some updates about autologous stem cell transplantation. My disclosures are important. I'm advising many companies, as you see, that develop drugs in Scleroderma. And I think this is a good thing. I don't understand why people are critical, but it's also important to be very transparent. So here you are. And some of them also develop cellular therapies. So that's important for you to know. But I think I'm really objective. I would like to start with CAR T cell because there's now such a lot of enthusiasm among the physicians, among patients, and the business world. There are billions of dollars and other currencies put into this new treatment. And I would like to share with you why, and also, as you already said, what our concerns might be. So this is the history. I think it's quite interesting. This is not a new therapy. This has been developed decades back, actually, where first reports of a so-called CAR T cell therapy were described. But it took until really the early 2000s when it was first tried in patients. And it started all in cancer, all in malignancies, hematological malignancies mainly. And then you see that in the 2012, there were the first approvals for treatment of cancers. And only after that, the first lupus models, mouse models, were tested if they were working with a CAR T cell approach. And then it was first analyzed in lupus patients. And only 2-3 years ago, the first case reports were coming from Scleroderma. So this is the history of it. So it's a long-standing therapy, but clinically approved it's only for a couple of years. And in autoimmune diseases like lupus and Scleroderma, only a very few years where the first reports were coming. So what is CAR T cell therapy? This is a cartoon that I think nicely explains it. In CAR T cell therapies, at the beginning, CAR T cells are removed from the blood of patients. So there's a blood drawing done. And in this blood, there are T cells. T cells are main immune surveillance cells in our immune systems. So they are there to attack and recognize and communicate the immune system against invaders, viruses, bacteria, and all other kind of stuff. And they are taken away. And now they are genetically modified outside the body in a culture dish. This is shown here. They are modified, they get a genetic information against what they should work, against what they should target. So you can put anything in here. This is important to understand. You can design this T cell to the target you wish. So here it's against cancer cells. So a cancer recognition protein is introduced into them, telling them you need to go against this cancer cell, which is characterized by this protein. go there. And this takes a while. Huh? This is in the culture dish, as we will see later. It takes 10 days, 14 days, at least a week. They're expanded. So out of that few T cells that are taken out of the patient's, the human being body, millions are grown in the culture dish. So they are stimulated, they grow, millions of cells are there. And then this is infused back to the same patient. So it's autologous to the same patients. And in the patient, there's then an explosion of these T cells. They are made to become more, right? They are made to proliferate themselves. So now there are, from these millions of CAR T cells, there are hundreds of, tens of millions T cells suddenly, 80-fold on average, more T cells growing in the body of the human. And now they are attacking what they have been made for. Here, for the cancer cell. They have this information on their surface to target the cancer cell. And they are really destroying the cancer cells with their proteins they have in there. They're just fulfilling their functions. This is their biologic function, right? They should destroy the invaders. Here, the cancer cell, which they got the information in the culture dish. This is the principle of CAR T cells. And this is how it has been made for cancer. So there's a cancer-specific surface marker that is informing them, go to the cancer cell. So in principle, this is the T cell that is in all in our body. There are many T cells in our circulation and also in tissues and lymph nodes and elsewhere. They are key fighters in our immune system. They get a new information, genetically modified with the new technologies. It's relatively easy to make. And you can you can get this T cell against anything you wish, almost. Right? There are a few technical limitations, but not many. And this is genetically put into the T cell, and now they have this genetic information on their surface, the receptor in yellow here. And now this receptor is recognizing the foreign thing they are made for. Here, the cancer cell. So then a group from Erlangen, from the University of Erlangen in Germany, around Georg Schett, were thinking, well, but if people were designing this against cancer cells, and their cancer cells were very efficiently destroyed as a very efficient therapy that was approved, why shouldn't we make this against autoimmune cells in autoimmune diseases? Huh? Because they are the bad players in autoimmune diseases, like Scleroderma. They started with lupus, which is a neighboring disease, which I'm sure many of you have heard before. They started with lupus. They were thinking, so why not making this CAR T cell against an immune cell that is an autoimmune cell? And they have chosen CD19 B cells. So they were designing the same way as here. They were now not putting a cancer information receptor in it, but a B cell information receptor. A B cell, a specific immune cell in our body. So what are CD19 B cells? When you look at the development of B cells, you realize they're all coming from stem cells in the bone marrow. Here's the bone marrow. The first three cells are the majoring, the growing of B cells in our bone marrows. There are certain stages that are characterized by different cell types, cell features, and markers. Then they are growing to become major B cells, plasmablasts, and plasma cells. So they major even more. And you see that CD19 is expressed along a large range of B cells. So when you let the CAR T cells work against CD19 B cells, they are working against a large proportion of the B cells in all development stages. And this is important to understand. And you already see which is one of their main functions. This is an antibody. This is the typical form of an antibody. The B cells, the CD19 B cells included, are producing antibodies. And now you already realize why the researchers from Erlangen were choosing CD19 B cells, because antibodies are obviously playing a role in autoimmune diseases, like lupus in particular, but also in Scleroderma. So what are they doing? What are CD19 B cells doing? This is confusing, I know. They are doing a lot. By purpose, this is confusing. They are producing antibodies. We already discussed this. This is up here, including autoantibodies, right? So, but they are doing a lot of other things. They are, you have to imagine the immune system as a kind of spider network. There are many connections between different points. So a B cell, for example, a CD19 B cell is talking to many other immune cells, like T cells, the B T cell interaction, which then stimulates against B T cells that release other inflammatory proteins. They are controlling a balance of certain inflammatory proteins. And also they are talking to other immune cells like dendritic cells. And this is then why they are involved in many different biological processes like wound healing, like tumors, like lymphoid tissue or organogenesis and others. So they are producing antibodies, but they are also doing a lot of other things in the immune system. So how does that look like specifically in terms of a timeline in the lupus trial that the Erlangen group was publishing? So first, the patients are seen. They are screened. Do they fit into, are they eligible for a CAR T-cell therapy? And then something that is called leukapheresis is started. So they are getting some medication that the different T cells are released from the blood, from the bone marrow into the blood. So this is done here. This is taking a while. And then the blood is drawn. And then the ex vivo, so culture dish manufacturing of the CAR T cells is taking place. As we explained, they get this technical information, produce CD19 in this case, produce the CD19 receptor that you later recognize the CD19 B cells that you should attack and destroy. This takes a while, and this is important to recognize. It's very challenging. They have to be clean, they have to be safe, there's no contamination allowed, so there needs a lot of double checks, safety checks, that this is working, the blue thing here is working well. This is usually done in a core unit, not at every hospital. And this is already a logistic challenge because the blood of the patient has to be sent under very controlled conditions to the central lab and has to be produced there. And it takes a week until the patient is seeing this modified CAR T cells back. And then there's something called conditioning therapy. This is to reduce the immune system, that when the CAR T cells are infused back into the body, that they can accept it, that they're not immediately destroying it as foreign cells. And this is, again, what you already know from stem cell transplantation. It's cyclophosphamide and other chemotherapeutics, but at a much lower dose, right? Then you know it from stem cell transplantation. And then finally, in green here, the CAR T cells are administered, and then the patient were observed what happened to them in the next, let's say, 10 to 14 days. So what happened in this clinical trial? Did this hypothesis work, that the autoimmunity was reduced, the CD19 B cells were removed? Was that truly happening in the patient? What happened to the immune system? It was really remarkable. You see on the left side, the graph, you see that the CAR T cells were rapidly expanding to 40 to 80-fold of the numbers they were infused. So there was a rapid expansion of CAR T cells. And then they disappeared. So they are not staying in the immune system, at least not in the periphery. Probably they are migrating into lymphoid tissues and lymph nodes and other lymphoid tissues, but they are disappearing from the circulation. And see what happened to the CD19 B cells they were targeting. So they were infused, and now they were in millions attacking the CD19 B cells. Look what happened within 2 days, they were completely gone. There were no CD19 B cells anymore there. And this stayed for a while, until for 2 to 3 weeks, until other B cells were coming back. So this is a complete removal of CD19 B cells. And you might ask, well, but I have heard CD19 B cell therapy before. Who has heard it before? There's a medication available. Who knows it? Please shout up. It's rituximab. Huh? Do you know Rituxan? This is an antibody against CD19, an engineered antibody that is also targeting CD19 B cells, but much less efficient. This is completely removed also from the tissues. It's a complete removal. You can't identify CD19 B cells anymore in the body. So, and the clinical effects, which is much more important, groundbreaking. Lupus, these were lupus patients that were absolutely therapy resistant to any therapy they had been tried on. They were in high disease activity. And you see that this is before and after. There was one patient who had a little this lupus disease activity, also after the treatment, but most patients did not have any lupus disease activity anymore. And this was long-lasting. After one infusion, this was long-lasting. So a kind of reprogramming of the immune system did indeed happen. I think nobody expected it in that intensive way. What about the antibodies? Indeed, they were almost completely disappearing, the lupus antibodies, the anti-native DNA antibodies, as you see here. Something clinically very challenging like fatigue was disappearing, as you see, normalizing almost in the majority of patients. So a groundbreaking effect. There's no free lunch. You can imagine that when millions of T cells, CAR T cells, attack B cells, there is then a sudden death of millions of cells, or at least 100,000 of B cells, of CD19 B cells. So they release cytokines. There's a cytokine release syndrome starting, which means you get fevers, you feel fatigue, the blood cells are disturbed. So there's a lot of inflammation ongoing because the cells that are destroyed are releasing cytokines into the system. And this is called the cytokine release syndrome. So this happened in 2 out of the patients, but it wasn't very severe. It was seen more severe in the cancer patients, probably because there are more cancer cells to be destroyed because they are much more because they are cancer cells. Okay, so what does that mean for scleroderma? This was all lupus. Does that also work for scleroderma? There have been, this is an overview presented by Christina Bergman in a paper in Press at the EULAR conference. Look here at the patient numbers of patients with scleroderma. 1 male, 1 female, 2 males, 4 male, 2 males, 1 male, 4 females. This is all we have at the moment. So if you count them together, you can do it, it's like 12, whatever, 15 patients, something like that. This is a very small number. As for the lupus patients, there are a bit more, but not many more. A small number we are talking about. Keep that in mind. We are talking about 15 patients. What happened to the scleroderma patients, to your patients with scleroderma? Indeed, the antibodies, if they were RNA polymerase III antibodies, also disappeared. It was slower than you have seen for the lupus antibody, for the anti-SCL70 or anti-topoisomerase antibodies that you heard before, right? But they also were reducing very significantly. What about clinical manifestations? You saw an improvement of the modified Rodnan skin score, which is the measure for skin fibrosis. So the hardening of the skin was indeed improving. Digital ulcers disappeared. The Euster Activity Index, which is a disease activity measure, improved. And the hand function stabilized. However, keep in mind that scleroderma is not simple. For example, if you take the modified Rodnan skin score, how do you interpret that improvement? And you keep in mind that in placebo-controlled clinical trials, the placebo group here in blue also improves spontaneously without treatment. It's very difficult to interpret at the moment. If this is more than the spontaneous decrease that we see in clinical trials, also in the controlled placebo group, or less or more, it seems to be a lot, but it's difficult to interpret. And the same is actually true for healing of digital ulcers. We see spontaneous healing of digital ulcers. This is a common phenomenon in scleroderma. So a bit difficult to interpret. What about the lung? There's a measure called FAPI-PET. This is a new measure that measures fibroblast activity in the lung. You see the reddish signal is fibroblast activity, and after treatment that had largely disappeared. This is a good sign because it might mean that the activity, the fibroblast activity, the fibroblasts are the cells that are producing the matrix, the proteins, the fibrosis. They seem to improve. But the functional tests like pulmonary function tests, forced vital capacity, that what you breathe in the lung function, are not changing. Whatever that means, they're not worsening, but no change could also be spontaneous course of the disease. So it's a bit difficult to interpret. This is a summary that was presented by Christina Bergmann at EULAR. You see the 12 patients that we were discussing. It's too complicated to read this, but look what different therapies down here had been tried in these patients. Many different, so these are severe patients with very severe skin hardening, with very significant organ involvement, and all these therapies that did not sufficiently work. And they underwent CAR T-cell therapy. And on the next slide, I like this a lot because different measures, different outcome measures, different activity measures have been applied here. What you see is that there is a large proportion of patients indeed responding, also in scleroderma, if you look at that activity measures. But it's not uniform. You also see red crosses here. One patient didn't respond at all. Others partially, they have a few red crosses here, partially responded. I think this is what we currently see in scleroderma with the 12 patients that have been presented. We see improvement in most patients. We see some improvement in most patients. We don't see a complete improvement like in lupus, where the lupus seems to have disappeared. We don't see this in scleroderma at the moment. So in summary, I think we can be hopeful. This is, in particular, what we see in lupus hasn't been seen before. In treatment-resistant cases, some of these patients are now 3 years after therapy. They don't need any therapy after they have been treatment-resistant before. So I think we can be helpful. The first results are very promising in lupus. I would say hopeful in scleroderma. If you look at the scheme with the many green crosses, it seems to be well tolerated. So far, we have not seen major adverse events, but only with 12 patients. Longer standing effects after one single infusion. This is at least remarkable. But we, by no means, can be sure. Far too small numbers. Imagine there's a side effect that appears in every 10 patients. We wouldn't see it with 12, right? So we need larger numbers. Far too small. Also the efficacy, very selected patients have now been studied. There's no control group. We need a control group that is not treated or treated with a control treatment to interpret these findings, in particular in scleroderma. They seem to be more heterogeneous here. The costs are tremendous. Guess about the costs. I don't know in British pounds, and I don't know in the UK, but in Switzerland, it's more than 100,000 Swiss francs, which is, I don't know the exchange rate at the moment, which is 1 to 1. So it's at least a 6-digit number. I was hearing even much higher prices for, if they're then commercialized, it might be even much more. And we talked about the logistics. So we definitely need larger control studies to interpret these findings, to interpret them in terms of efficacy, but also in terms of adverse events that we might not have seen with 12 patients that might be specific to autoimmune diseases that might have not been occurred in scleroderma, and to be good advices. But these trials are happening. This is the good news. With all that billions of dollars that are moved into that fields from industry, trials are done, controlled trials are done, because also the agencies are requesting controlled trials to approve this therapy. Okay, how much time do I have actually? Stem cell transplantation. Stem cell transplantation, you might have heard. I just want to give you an update here. This is the scheme. Stem cell transplantation is something different. Here, you administer a pretreatment that is removing that is mobilizing the blood cell, the precursor cells, the blood precursor cells, the immune precursor cells into the bloodstream. Then the bloodstream is collected, and now the stem cells are taken out and expanded in the culture dish. Only stem cells, not specifically designed against something. It's the stem cells, the precursor cells of our immune systems. They are removed. The blood is frozen or treat it accordingly. Then you get a high-dose chemotherapy, which is much higher than you have seen with CAR T cells, to really remove the immune system completely. So you're aplastic. You don't have an immune system for 2 or 3 weeks, I think. And then the precursor cells are given back to the patient, the expanded precursor cells, and the new immune system is building up. And this is then followed up. So a very different situation, a complete removal of the immune system, not a modification of the immune system. And there's a clear statement. We have a much better evidence basis here for stem cell transplantation than for CAR T cells. There are at least 3 well-done randomized controlled clinical trials done. 2.5, I would say. One had to be stopped earlier because there was such a strong efficacy leading to small numbers, but two were very large. And this is the Estes trial, the European trial. And there's a clear, this is survival here, a survival benefit after more than 2 years under stem cell transplantation, which is HSCT, versus control, which is cyclophosphamide intravenous treatment. So there's no question. The 3 trials are all in the same way. And if you also look at other outcome measures, it's clear forced vital capacity is for the lung. There is a significant difference. You can look for even the physical component of a quality of life questionnaire, which is significant. So there's a clear effect. No discussion. We don't know this for CAR T cell at this time. There are indications, but we don't know. However, this is Hippocrates of Kos, a bioethic philosopher, actually. And he made this important statement: primum non nocere, first don't harm, abstain from doing harm. And this is the problem with this therapy. It's such an intense therapy that it has significant adverse events. And there's a psychological analysis of patients undergoing stem cell transplantation. You see here some statements of patients. This is a qualitative interview. My fear was not to survive. I spat every time. You have to go to the bathroom all the time. You can't walk, so you get a potty. I couldn't eat, I couldn't drink. So this is not a simple treatment, to make this very clear, also in your own words, actually. But at the same time, most patients were satisfied with the time after the stem cell transplantation. This was during the stem cell transplantation. They would recommend it again, and they were happy afterwards. But the time during the stem cell transplantation, the weeks there without an immune system, this is not easy. And I think most important is that thing at the beginning here. There is a decreased survival in the first 2 years under treatment. So there's a treatment-related mortality of up to 10%. This is very meaningful and very difficult. You have to decide if you go the risk of a 10% mortality due to the treatment, if you want to have that positive effect at the end. Very difficult decision. And risk factors are not easy to identify. There have been a couple of studies, but they're very remarkably inconsistent in identifying risk factors for mortality, for the treatment-related mortality. Some are listed here. If you're smoking, that's more difficult. Heart involvement should be avoided. Higher age, male sex, very short disease duration, already reaching a bad, severe disease measure severity is a bad sign, but none of them has been really confirmed across trials. And of course then, I think the problem here is the patient shared decision-making with you, the patients. And this is possible. This is a study Cosimo Bruni and we published a couple of years ago where we asked patients, so if you can get this benefit in quality of life, are you willing to take that risk of, getting that side effect, taking an infusion every week or something? So that was possible. The patients very nicely could differentiate these different choices. So choices can be made. Decision-making is possible with patients. You can achieve that. But are we doing it well? This is a study from the Netherlands, from Julia Spearings, where she was, again, in a quality interview, so we're talking to the patients that underwent stem cell transplantation. She was asking, so how were you satisfied with the decision-making process of choosing stem cell transplantation or not? And she identified different ways how physicians were doing that in patients. So, they got treatment option 1 and had to do yes, no. Then treatment option, if one was yes with the patient, they went for this one. The same then with option 2 and option 3. Or they were offered these treatment steps. So first we do this, then we do this, and then we do this. Are you happy? Or they were offered the options all in parallel. We have the following treatment options: rituximab, CAR T-cell, stem cell transplantation, whatever. And then they were discussing the pros and cons, and the patients was making preferences. This was preferred by the patients all at once. But it's so complex that it's sometimes not easy to communicate. And indeed, more than half of the patients reported they could not oversee and balance all options, and they lacked the information to be fully involved in the treatment decision. So there's no material available in lay languages. The physicians are not trained to do this. It's their bias because they also have an opinion according to what they believe is most important and maybe of most benefit. So this is not an easy task and leads a lot of education to the physicians and maybe the patients to also guide the communication and the patient decision making. Are there alternatives to stem cell transplantation? There's one study, the last study actually, that I would like to show you. This is a study from Israel published relatively recently, and they compared stem cell transplantation with 16 patients to combination therapy of MMF and rituximab, mycophenolate mofetil cell sept, and rituximab or Rituxan, however you call it in your country. And we don't go to the details. They were all severe patients. They were relatively balanced. But remarkably, at 12 months, there was a clinical improvement shown in 81% of the stem cell patients and 86% in the combination treatment group. So almost the same. So there are alternatives available now within many new treatments that are developed. And this is a similar analysis which even favored the combination therapy group. Event-free survival. EFS is event-free survival, so survival and no end organ damage. And the adverse events were the same as we already discussed them. The treatment-related mortality in stem cell transplantation was 18% here. So 3 out of 16 patients unfortunately died during the stem cell transplantation procedure. So it's not an easy decision. Despite it's very clear that it's efficient, it's not an easy decision. So in summary, I think stem cell transplantation is an effective therapy, almost no discussion. It suffers from adverse events, in particular treatment-related mortality. What have I done? Risk factors are insufficiently established. There's no treatment for patients without patients. But shared decision-making needs training. We need to improve there. It's also expensive, unfortunately. We also talk about the same price range almost. And there are alternatives available, and we have to see whether these combination therapies are truly the same efficacy or not in, again, randomized controlled clinical trials. Thank you very much.